Recording is on. Feel free to start when you're ready.
My name is Megan Bird, and I just would also like to acknowledge my colleagues that worked on this project, Dr. Samuel Peer, Alyssa Carell, and Christina Strock. And we are from Idaho State University, and this is titled PCIT for Middle Childhood, Mechanisms of Change in an Adaptive Protocol. PCIT is a best practice treatment for disruptive behavior in children ages 2 to 6, and evidence has been found to support adaptations for infants as well as toddlers. In contrast, PCIT adaptations for older children have lagged. Past support is limited largely to 3 individual case studies using different protocols. Each of these programs adapted CDI and PDI in different ways. Some increased homework time, some decreased mastery criteria, or did not require behavior descriptions. For PDI, timeout protocols varied widely, including hands-off, swoop and go, and incentive charts and suspension privileges. In contrast to this, PCIT-MC is a standardized protocol for ages 7 to 11 that has been used for multiple cases. For the CDI phase, there is no adaptation, just tailoring. So for both the CDI teach and coach sessions, tailoring was done for examples and rationale, as well as activities and toys, and the pride usage for the reflections, behavior descriptions, and label praises to be more developmentally appropriate for the children. In contrast, PDI is heavily adapted for PCIT-MC, namely, timeout is not used because it is less developmentally appropriate and increasingly unsafe physically for middle childhood. Instead, a token economy is used. Caregivers are first taught why and how to create a token economy with operationalized child responsibilities and privileges, and caregivers are then taught to incorporate response cost into that token economy, where children lose points for non-compliance rather than timeout. Both skills are first taught in separate teach sessions, and then coach sessions are used until caregivers complete mastery consistent with traditional PDI. Results from a PCIT-MC pilot trial support its efficacy in improving child disruptive behaviors with a Cohen's D of 2.37. In addition, results suggest PCIT-MC improves caregiver skills, namely the overall composite valence of verbalization change from negative to positive in pre to post treatment. Specifically, positive verbalizations increase and negative verbalizations decrease to a significant degree. In terms of reducing disruptive behavior, PCIT-MC effect size is approximately 3 times larger than other best practice treatments for middle childhood. And additionally, changes in do and don't skills are similar to traditional PCIT and other adaptations. No research has yet tested whether or how changes in caregiver skills predict changes in child disruptive behaviors during PCIT-MC. Our main hypothesis is cross-session changes in CDI do skills and don't skills will significantly predict subsequent cross-session changes in child disruptive behaviors, but not the converse. More specifically, increases in do skills will predict a decrease in disruptive behavior was hypothesized, as well as decreases in don't skills will predict decreases in disruptive behavior. For this study, there were 4 children, approximately around the age of 9, and they were mainly non-Hispanic boys, and the majority of the caregiver were women. More specifically, the children ages ranged from 8 to 10, and they all included a diagnosis of ODD, and with some including comorbid diagnoses of ADHD, PTSD, and enuresis. The majority of the parents or caregivers were biological mother and father. However, for one case, it was residential care staff. And to avoid nesting, only primary caregiver data were used. Constructs were assessed with PCIT-MC progress monitoring data collected each CDI session. Specifically, DPIC scores for child-led play were used, as well as ECBE intensity scores for child disruptive behaviors. Multivariate simulation modeling analyses were run to test significance of lag correlations at lags -1, 0, and +1 and simulations equaling 1,000. As this figure shows, consistent with prior results, the disruptive behaviors for each case decreased, and the parent do skills increased and their don't skills decreased. As hypothesized, changes in overall caregiver skills across sessions predicted child behavior. Each show correlations. So the triangle represents the p-value and the black triangle represents a statistically significant p-value. Improvement in caregiver skills predicted decreases in child disruptive behaviors with correlations ranging from -0.83 to -0.96. And the lag 0 is the only one with statistically significant correlations for all 4 cases, which suggests that changes in caregiver improvement predicted child disruptive behaviors as represented by the ICB scores. In contrast, child behavior did not predict parent behavior as seen in lag -1. So what's driving change in ICB scores? This shows that increase in do skills leads to a decrease in child disruptive behaviors. And it also shows that a decrease in don't skills lead to a decrease in disruptive behaviors instead of the other way around. So it is the parent skills that are predicting the children's behaviors. These findings are consistent with past work indicating that caregiver acquisition of do skills and extinction of don't skills can predict or mediate child behavior change. However, there are some limitations for the study. We did have a small sample size, only including 4 participants, and there were no children older than the age of 10. We also had lack of experimental controls, and the cases all included mild to moderate but not severe aggression. However, notwithstanding, these findings do help to establish PCIT-MC's mechanisms of change, and they're convergent with standard PCIT, consistent with recommended validation criteria for type 2 scale adaptations. And for future directions, we suggest replicating these findings with larger, older, or more diverse samples, and assess the relations between changes in specific CDI do and don't skills and changes in child behaviors disrupted and prosocial, and examine the degree to which PDI-focused caregiver skills, such as the use of direct versus indirect commands and warnings, increases during the PDI phase of PCIT-MC, and in turn predict further improvements in child behavior, as well as assess other potential mediators of PCIT-MC improvements, such as therapist coaching techniques, didactic presentation styles, co-parenting, and homework. And these are our references. And then this is the actual poster. And I just want to thank you for allowing me the opportunity to present this research. And if you do have any questions, please contact me or Dr. Samuel Peer. Thank you.
All right. Thank you so much for that great presentation looking at PCIT MC, middle childhood.
Mm-hmm.
Okay. Yeah, actually, in our office currently, doctors Kate Gibson and Caroline Harvey are working on the PCIT older child manual. So this is kind of a different, not very different, but you're on this research aspect of showing, how these adaptations and changes are actually very beneficial and lead to the same decreases in child behavior as typical PCIT for a population that's just outside of it, in a way that they are standardizing that approach. That's kind of an interesting 2 sides of the same coin that's going on there. Mm-hmm. So that's one of the sessions that's happening. But it's very interesting. How did you see with the 4 children, the adaptation of PCIT-MC, kind of specifically, how did it work across the clinicians? You kind of briefly went over what the changes were, but I know you mentioned some changes in the pride skills themselves. Can you
Mhm.
speak to what modifications you use specifically?
Yeah, so we didn't actually really change the pride skills per se. It was just more like the rationale and the examples that were given to the parents, like why we're using these pride skills. Um, so, for example, like with reflections, a lot of times it's taught that you use reflections to help increase the child's language, but potentially these children, because they're older, their language is going to be fine. So it's more about like rephrasing instead of just like re repeating exactly what they said to help them feel validated. And so it's not as much about the language component, but more about the making them feel heard and validated. So those kind of things. So it's not actually that those were changed. It was just like the rationale behind those and explaining and giving examples to the parents in the sessions. That's what was more tailored. Does that make sense? Did I answer your question?
Yes. And in this
Okay.
approach, mastery criteria was kept the same. You
Yes.
met 10 for each.
Mm-hmm.
Okay, great, interesting. And what did PDI look like? Kind of what were some of um, the modifications or adaptations you made? I know you briefly went over this, but kind of this,
Yeah.
anecdotally, how did it work out?
So it was they had like a token economy instead of timeout. So um, in that they had the two different like had like sub phases within the PDI. So first they talked about the token economy and the like children's responsibilities as well as privileges that come with those. And so it helped the parents and the children collaboratively work together to decide what those privileges would be based on their responsibilities. Um, and then after that, it came back and checked in with them to make sure that both the parent and the child were understanding what was going on and that their child had like bought into the privileges and the token economy and that it was actually working. And if that was the case, then they moved on to the response cost, or yeah, the response cost phase, which is when they would start losing points if they weren't listening or following through. So they were also taught to give warnings and then as well as consequences which would be to lose a point if they didn't follow through with the command. So the parents were taught like the effective commands. Is that answering your question?
Yeah,
Okay.
definitely. Helps kind of picture it a little bit more. I know it's sometimes challenging with older children, but you do still see that need. But yeah, it sounds like very interesting. Sounds like you're looking more towards expanding and
Mhm,
building out, seeing that generalizability with different
mhm.
populations.
Yes.
So thank you so much for your presentation.
Thank you.